Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. I'm excited to bring you another in our series of interviews with top leaders in health IT. And today's guests are Dr. Jed S. Rosen. He's Regional Director of Medical Informatics at LifeBridge Health. And we also have Dr. Rishi Sarna. He's Chief Medical Officer at TransformativeMed. Welcome, guys.
Thanks for having us.
Thanks, John. Thanks, Jed.
Yeah, I'm excited for the discussion. And I think the topic is so spot on with to be frank, all of us are dealing with burnout and the challenges of, of using technology and having it help us rather than hurt us. But before we dive into that, Rishi, you want to start and tell us a little bit about yourself and your organization?
Yeah, like you had mentioned, John, I'm the Chief Medical Officer at TransformativeMed. What we do is we pretty much take your EHR and we make it a lot simpler for you. We're not a app that lives outside your app. We actually live inside your EHR, whether it be Cerner, whether it be Epic. We pretty much just take all the data and we kind of put in one area. So physicians and other healthcare providers are not spending endless hours and time searching for pertinent patient data. The analogy I always give is imagine a Lego box. And you get it, and then as soon as you get home, that Lego box explodes everywhere, and now you have to look everywhere for those 10,000 pieces. What we do, take all those pieces, we put it right in front of you, so you can build that nice little model for you, or in this case, that patient summary that you need.
Wow, what a great description! Great. Well, looking forward to the discussion. Jed, you want to introduce yourself and your organization?
Yes, my name is Jed Rosen. I am a otolaryngologist, ear, nose, and throat surgeon by training. I spent almost 11 years working as electrical engineer before going into medicine, practice at a private practice for almost 30 years. And instead of retiring, went into IT. And now I'm the Regional Director of Medical Informatics at LifeBridge Health, which is a 5-hospital system in Baltimore.
Wow. Well, I didn't think your retirement would be IT, but that's quite an interesting retirement choice. And it's interesting that it's counter to what's happening in the rest of healthcare, it seems. I mean, we have the Great Resignation we hear about people all burnt out, and it's really become a problem in healthcare. Jed, maybe you could kick us off. What's been your experience with this? Any stories that you could share?
Well, yeah. One of the reasons I decided to pull back from clinical medicine was the requirements that were being placed on private practices. I was in solo private practice, not affiliated with anybody. Mm-hmm. And the regulations really built up to the point where it was almost impossible to stand alone. I guess I was fortunate in that I wrote my own EMR for my office.
Wow.
And used that for probably 25 years, and even got it certified in Medicare so I could electronically bill directly to them. But as things got more and more and more, it got to the point where we kind of said, getting to the end of my practice, my wife was running my practice for me, and she was getting to the point where, was it really worth it going on? And I had always been kind of a big mouth at our medical executive committee, because I was also chief of surgery for 15 years.
Wow.
And they finally just said, listen, if you can do this better, why don't you come to the dark side and come work with us? And so I closed my clinical practice and was a CMIO of our hospital, our local hospital outside of Baltimore, until we were acquired by LifeBridge. And then they offered me the position that I'm currently in. So, I could really identify with burnout because I went through it. It's just too much to do for a single person. Now, if you're a member of a big practice, there's less pressure to do that kind of stuff. But when you're by yourself, it's really difficult.
Yeah, but I think it's also happening for the individuals, right? I mean, to your point, the requirements, the regulations, the reimbursement requirements are quite overwhelming for clinicians. Is that what you're seeing as well, Jed?
Absolutely. The number one complaint I get, and being the chief of a department, and then going into the becoming kind of the part of the administration to some degree, we get a lot of complaints. And the number one complaint we get from our providers is, it takes me too long to do what I'm asked to do. before, when I was on paper, I could scribble a note very quickly, put it in the chart where nobody could read it, and then move about my day and take care of patients.
Yep.
And as the EMRs started out, they were documenting, being asked to do these things that really slowed them down. I mean, even the most conservative studies have shown that about 25% less efficient just in the EMRs alone. And that's for somebody who's familiar with the EMR.
Yeah.
So, you're asked to document a lot more information, takes a lot more time. And it's only been the last couple of years where we finally decided as an industry to start lessening that burden, lessening that load. So the big buzzword for this year is burden. You see that at all the conferences. How do we reduce the amount of burden on our physicians?
Yeah. Well, we're going to dive into that. Rishi, any stories you'd share that, you talk to a lot of organizations, what's kind of the compelling stories you're hearing?
Well, the biggest thing that comes down what Jed said is, burden and burnout go hand in hand. If you increase the burden of documentation, it's going to lead to a progressive burnout, meaning that, this is the thing we take pride at TransformativeMed, with our cores module, is that if we can save you 10, 15 minutes in the morning, preventing you from, looking in the EHR, finding that data, that 10, 15 minutes can be the difference of whether you eat lunch or not. And that personal satisfaction, be able to sit down, have a meal, that's going to re-energize you. There's so many times in my training, because I was kind of in that, weird, transition where when I first started med school, we were on paper. And then all these hospitals started creating their own mom and pop EHRs. And we were sold on the fact that it's going to be quicker. But in fact, it actually was like Jed was saying, it was more cumbersome. We had to document more. And then when you're actually searching for, in one section labs, one section vitals, one section medications, one section's previous notes, one section, what other department, what did the consult doctor do? Now, again, it's like you're searching for these pieces where when it was in a paper chart, you could just flip back a couple of pages. Now, granted, the downside of that was handwriting. I guarantee Jed had some pretty bad handwriting. I got commended as having the best handwriting 4 years in a row in med school. So I'll wear that with pride. It also took me like an hour and a half to write notes. But I think the biggest story is just not one that comes out, is that every one of our clients are like, I actually sat down and I actually ate today, or I actually sat down and I actually got ahead of my pre-charting. It's not as necessarily you saving you time. Like, it's not like you're going to go from 7 a.m. and then end at 5 p.m. You're still going to work your full hours, but you're going to get a lot more done. And so that's the biggest thing. If we're helping with that, then it's a success.
Jed, is that what you see as really the core of the problem? Like, I hear nurses and doctors all the time, complain about I don't need another wellness program, another yoga room, right? I don't need to be more resilient. How you actually help me with the core of the problem that's burning me out? Is that what it is? Is it's the overwhelming documentation burden that we talked about, or are there other elements as well?
Well, it's multifactorial, without a doubt. I mean, the documentation burden is very real. It's the bottom line is simple. How do I either see more patients, take care of my backlog of patients, or how do I get done earlier and get out of here? Mm-hmm. The overwhelming majority of physicians that I know, and including myself, we would document well into the evening. You go home, you maybe grab a quick bite to eat, and then you spend an hour or two back on the system, finishing up everything you were trying to get done earlier. So if I can cut off, maybe an hour of my day earlier, that means that I have more time at home. I can get home and I won't have to get back on the system in the middle of the night and to do that. And remember, most of us take call. So we're responsible for our own patients and responsible for covering portions of the hospital. So at any minute we could get called and have to go do something. And we don't want to have to be catching up with the day's work. So if I can cut off a few minutes during the day, that makes me more efficient. That decreases the burden on me and decreases the chances of burnout. And to be honest, one of the things that we came across when we did an engagement survey 2 years ago was it takes me too long twice a day, I have got to find out what's happened to my patients. Okay, we call that a handoff. Okay? Twice a day that occurs. It occurs in the morning, and I'm talking to the people who took care of the patients overnight.
Yep, absolutely.
And talking in the evening when I'm ready to go home. I have to talk to them. Traditionally, I'm sure anybody who's been through it can relate to it, is that this was all done on a 3x5 card, or maybe if you were fancy, you had a 5x7 card. You could write as small as you possibly can in writing that nobody else in the world could possibly read. And then you would put all the information you needed on that. And then when you went to leave, you handed it to the person who was doing the night call. They'd look at it and they'd kind of frown at you and go, what? And then, you have to sit there and explain everything to them. Go over and you'd open the chart or even go through the computer and you would go through all the data. This is what I need. This is what's going on with the patient. What can you, help me get this done? And if there's an abnormal thing, call me at 8 o'clock tonight after you take a blood test or something.
Yep.
And it was incredibly time consuming. Preparation times of 45 minutes to an hour to get the information, and then maybe 20 to 30 minutes to discuss it with the
Yep.
people. And that was something that was really holding us back. So we were very much interested in looking at what we call handoff tools, and we looked at several and trying to figure out which one would cut off the most amount of time, for our people. And the one we settled on, worked out about a 45-minute per user time saving. So that means I get out of the hospital 45 minutes earlier. And to me, that's really important. So if I get a consult, I can go see the consult without having to, panic about, I'm not going to, I'm going to be home late and my wife's going to be angry at me and all that nice stuff. So
you use technology to solve that. It sounds like. What's the workflow look like now compared to that previous note card example?
Well, the workflow now is now I see it with our residents, and we see it with other attendings. They come down to a central area, usually the doctor's lounge or cafeteria or something like that. We all huddle together with masks on if it's a COVID area.
Sure.
And then we sit down, and we've already set up our patient list. So we simply open up our patient list. All the information is right there in a form that is logical for users. And let me just take a step back for a second. One of the big problems with that EMRs in general is, and I'm going to diss my own profession, they were designed and built by engineers, software engineers, electrical engineers like myself, sat down and built it. And as from being a database nerd, it's great. It's designed really well as a database. It is not designed well for the providers. I don't care if you're in Cerner, whether you're in Epic or Meditech, makes no difference. They're all virtually the same. Okay. So what we were hoping for, and what we're hoping that the future trend of EMRs are going to be, is that they're going to get much more input from the providers. So I want something that looks like the way I work.
Yeah.
So now what we do is we sit down, and the printout that they develop for each one of these has a very concise summary of what they did in the way that doctors have been trained to look at it. Stick figure for the blood tests and columns for all the other information that's very concise, and we can go into it. So we basically sit down, run the list real quickly, making sure everybody's on it that needs to be there, and take a look at it. And it's got a list of all the stuff that needs to be done. Just say, okay, remember to get a blood test at 8 o'clock tonight. I'll see you tomorrow.
Wow.
Out the door we go. If there's an issue, I can pick up my phone.
Sure.
And I can look at the results on my phone. Get home, I can get on the computer if I need to. If a question arises in the middle of the night, I can see exactly what's going on. I don't have to hunt through the EMR anymore. It really has, I have cited to my superiors that we've cut off about 45 minutes per provider per rounding, 2 rounds a day, usually anywhere from 3 to 15 providers at a round. that's a substantial savings of time.
Yeah.
It really is.
Is
So-
there a better treatment for burnout than giving time back to the provider? Probably not, right?
No, it's not.
Yeah. Well, and to your point, I mean, it was built as a database, but it was also built as a billing engine, not a clinical engine. I think that's why it's reflected with the HRs.
Yeah,
So-
exactly. We don't talk about that side of it. Right?
Well,
We're
you got to
not
pay the
allowed-
bills.
We're
So
not
it's
allowed
important.
to talk about that.
No, indeed. Rish, what would you add? I mean, you kind of cited that tech promised that it was going to solve some problems, didn't live up to that billing completely, right? So, how do you see, tech really helping solve the core of the problem of burnout?
Yeah, well, first of all, Jed, after this podcast, you're going to have to apologize to my father. He's an electrical engineer as well. So he's not gonna
There's a lot of engineers, but they know it. They know
yeah,
it.
yeah, they know. It's actually funny bringing that up. Is when I was in med school, we do some rotations at home, and you kind of build it around that. And I come back and I would just be frustrated. My dad's like, I don't understand how this product, what's built by health or it's used by healthcare providers, why was it not built by healthcare professions? And when I mean a product, he means EMRs. And I was like, Dad, I don't even know where to begin to tell you with this, why this is happening, built by electrical engineers and other engineers. And at Transformative Med, with our cores, with our cores platform, our entire platform, we call it cores. We have a diabetes solution, we have a mobile solution, a notify solution, and the biggest thing, which we pride on, is our workflow solution. And the big component of that is handoff. And so this is where technology comes in. And it's like what Jed was saying is your 3x5 no card. And then that sometimes expands by 8x10. It got where my training got even more, where it became like a 10x15 sheet. And you're folding it and you're putting in your lab coat. And then you would sit there in the cafeteria and you'd compare notes. And now you're going, you're reading it and you're like, we have a computer in front of us. Why am I still doing analog stuff? What TransformativeMed pretty much took, just imagine, you see, the movie Minority Report, you just take the screen and you throw it on like that. Yeah. Imagine taking the analog sheet and just throwing it on your screen. And now you have it right there. And so now, instead of it being an outside app, it's actually like I said, I apologize to keep embedding this point, but it's embedded in the EHR. We would have false hubris to say that we're the only company to ever have a workflow solution, a handoff solution. But we truly are one of the very few companies that when you're using it, you don't actually realize you're using our solution or using our platform. I've rounded with a lot of our clients and they'll come to me and they're like, oh, are you with this EMR? Or are you with that EMR? I'm like, no. I work for Transformative Med. And they're like, what's that? I'm like, that handoff thing you're using? Like, you guys came up with that? We're like, yeah. They're like, teach me, like, how did you do it? And I'm like, this is the beauty of it. It sounds a little cliche, but it truly is a platform built by clinicians for clinicians.
Yeah. What's the clinician experience like when you implement a real clinician workflow solution like this? I mean, what are some of the experiences you've heard, Rishi, from your customers?
They literally say how easy it is to use. It takes very, very minimal, training on them. Like I said, it's almost like plug and play. It's not like, we're going to each site and teaching, having classes. It's pretty much you plug it in and you're ready to go. I always say, whether you have an Android or whether you have an iPhone, if you're having to download an app and then taking time to learn that app, hours on hours, how many times are you going to download a new app? You're never going to do it. So that's where, again, the technology component comes in, is that, every time I worked at a hospital, you would hear about this new solution. And Jed, you can relate to this. All the doctors would just roll their eyes. They'd be like, no, I don't have time to sit in another 8-hour class. I don't have time to log in and do a 4-hour virtual training. Just, I can get the credit and you can get off my back. With us, it's like, okay, we're going to, again, embed it in your EHR, and you're going to see this new thing that says cores. You're going to click on it and be like, I wonder what this is. And it's seamless. And so that's the biggest feedback I get from, whether it be doctors, PTs, whoever. They're like, this is so easy for me to use that I don't know why I didn't have it all along. So that's the biggest thing we hear all the time.
Yeah. Jed, do you bump into that where you get some resistance to this type of change? Like, oh, well, shouldn't the EHR have solved this? Why are we buying another product? Right. Like, how does a CMO like get buy-in for a workflow solutions like this?
Yeah, well, the first thing is on the physician side, on the provider side. I'm not talking about just physicians, nurses, NPs, PAs, all that stuff. The first thing I hear from them as soon as I say we're going to try a new product is no. They don't want to.
It's the default no. It's so true.
No.
Ed, are you sure? Are you sure there's not something else that precedes that no? It's not just.
Oh yes, there's often very colorful language that we can't use here. And they very, very resistant to change now. We've gone through so much change in the last 10 years. Nothing. We just can't do it. And then I get the pressure from the finance side that says, we've got very limited budgets. What is this going to do for us? Is this going to make it so that we see more patients and therefore generate more income, get patients through the hospital faster, therefore generate more income? They want to know what the financial benefits are there. So it's a real balancing act. When we implemented our most recent solution, to be honest with you, the initial response was, the initial thought was no, they didn't want to do it. Okay, so we tried a little pilot group, and they really liked it. I was shocked. They really, really liked it. They started telling me how much time it's saving them and all that kind of stuff. And one thing that was really big, it's saving them clicks. Doctors and nurses count clicks. And they want to know, are you going to take away a click? And if the answer is yes, then they might think about it. So they were really excited about that. And then something that has never happened in my entire career, whether it be engineering, when I was designing components for radar systems, to medical school, to IT experience, I have never had providers, or the customer in this case, come up to me and ask me for the application. This case they did.
Wow.
And they still do.
And was that because they saw and were jealous of their peers that had it and were like,
that's exactly
I want
what
that?
they were. They saw their everybody tends to round together. There'll be a cafeteria, There'll be 5 or 6 tables full of folks signing off. Their tables were leaving earlier. They have more patients. And
the competitive
going, well, how can the general surgeons get out of here faster than the neurologists? No, that's not going to happen. So they find out, they get it through the word of mouth. And I've also had people who have gotten into the system and are using it who weren't set up to use it. And they set themselves up and they went ahead and used it. And I was like, how are you doing that? I said, well, it's very simple. I just click, 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 and I'm done. Wow. First time that's ever happened to me.
Interesting. Rishi, how do you look at this? I mean, from an ROI perspective, right? I mean, I think everyone's doing that more. In fact, I wrote an article on healthcare IT today that said the days of just implementing because we're chasing government money are done. We need to know the ROI, right? So how do you look at the ROI of implementing a workflow solution like TransformativeMed's core?
Yeah, with cores, you're actually looking at 2 types of ROIs. You look at the clinical ROI and then you look at the financial ROI. When we're sitting with clients, obviously, depending on who you're sitting with, if you're sitting with the CFO, they want the financial ROI, obviously. The biggest thing we highlight is anyone playing clinical medicine, that if you're able to discharge your patient before noon, you have a smaller percentage of them staying the next day. If you start writing discharge orders around 4 or 5 p.m., there's a good chance that patient's going to stay a little longer and even longer. And then you're like, at this point, it's just considered another stay. Or like Jed alluded to, back in the day when you're doing 3x5 no card, 8x10, whatever, that's wasting time. That's you're not efficient. Now, if you're saving anywhere between 30 to 45 minutes, you have time now to write those discharge orders and get that patient out before noon. And this is a metric that hospitals look at. What is our percentage that we're doing before noon? And if we're even as Transformative Med to increase that by 5-6%, that is huge financial savings for a hospital. I mean, to a point where when we're showing clients, they're like, I don't know if we believe these numbers. And then you just have them talk to other clients. They're like, no, this has definitely improved our discharge before noon, at levels we never thought. And so that's the biggest thing we measure from a financial standpoint. Now, from a clinical standpoint, we've kind of touched upon it, but if you're saving your clinicians 45 minutes a day, I mean, think about retention you're going to have. Think about reducing burnout. And Jed, you can correct me if I'm wrong, but the biggest reason why physicians leave, it's not because of money, it's because of burnout. Especially during COVID, when you had physicians and nurses just work to the max. Like we had one of our most well-trusted clients come out to us. They're like, we need help with COVID. We're having a horrible time tracking it, and we are losing people left and right. And with our core solution, we customize that for them. That's the one thing where we're not just a black box thing where do it our way. We actually work with all departments at your hospital, and we customize it. So what a surgeon might see in their view is going to be different what a neurologist will see. What a neurologist will see, it might be different what a pediatrician will see. So that customization right there, it's like, what does your department need? Again, that ultimately saves each department time. And so if you're telling me the biggest thing, if I'm going to be applying for a job, I'm going to ask, what's the average time a doctor is spending the EHR? These are the questions that new generations are asking. Not like, what are my work hours like? Not like, when do I get lunch? How much vacation time do I get? How much time is the average physician in my department spending in the EHR? And that's what Jed was saying. That comes down to clicks. Less clicks you have, the more free time you have. The less time you're spending looking for those Legos, as I alluded to earlier, the more time you're going to have. And that ultimately decreases burnout, physician satisfaction, and now you've increased your clinical ROI. So I always look at it as a two-way avenue.
Yeah.
Another area that a lot of people don't think much about, but we have already seen an improvement on, is observation units. If you get a patient out by before noon in terms of an inpatient discharge before noon, that's a great metric. Okay. But as long as they're not there after midnight, that doesn't really change the dollar value of their stay. It does in reporting to the federal government, but not in terms of what the carrier is going to compensate for. In observation, every hour counts. Okay, so if I can get a patient out 1 hour faster, that makes a huge difference. In not only the care of the patient, because it's the proper treatment of the patient, because most of the time they're sitting doing nothing. You're waiting on a lab result, you're waiting on a test to get done. So the faster I can get notified about that result, the faster I can respond to them and let me do other work while I'm waiting for it. I don't want to have to go back to the chart. I'm working on somebody else, I'm admitting another patient. I don't want to have to go back to the chart for a previous patient, scan through it, find out whether the result was there. Hopefully the nurse called me when the result came in, which she's busy or he's busy too. So that's not going to happen. I need something that's going to tell me right away, either through my phone or through texting or through email, whatever method I set up, that has to be done. And that has made a huge difference in our time to observation. So that's something that the financial guys, they can measure that.
Yeah.
They like that. They go, your average time of observation went from 26 to 24 hours. They jump up and down and do the dance. That really is a big deal. And most people forget about that. But that's a part where, handoff is communication. And that's what we're trying to do. We're trying to get better communication between caregivers so that we can expedite care and have better quality care.
Yeah. I mean, I would summarize this, in our whole discussion today is creating a workflow that's focused on the clinician, and what a powerful, solution that is. And interestingly enough, it has the financial behind it, but I'm seeing more and more that CEOs are going to be driving the requirement that the workflow for the physician has to be better, as Rishi says, from a recruitment standpoint and from a retention of staff standpoint, which is, I think the topic of 2022. So I want to thank you both so much for taking part in this discussion, sharing these insights and perspectives, and working on this incredibly challenging problem of burnout, and all these people resigning, and how do we make sure we retain them in the best way possible. So thanks so much for sharing your ideas and insights, and thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, guys.
And thank you so much, John.
Welcome.